Neonatal jaundice. This refers to the yellow discolorization of the newborn skin and the sclera due to the elevated levels of bilirubin in the blood. Hyperbilirubemia. It is a common condition affecting about 60% of term and 80% of the preterm neonates in the first week of life. Types of the neonatal jaundice. Psychological jaundice appear after the 24 hours, peaks on day 3 to day 5 and resolves within 1 to 2 weeks due to the immaturity of the liver's conjugation mechanism. Pathological jaundice like appear within the first 24 hours or persist beyond the expected duration. May indicate the underlying disease. Causes of the neonatal jaundice like unconjugated, increased bilirubin production, hemolysis, RH or the ABO incompatibility, J6PD deficiency and the hereditary spherocytosis, bruising and the cephalohematoma, decreased clearance, immature liver enzyme, example glucoaryl transferase deficiency, breastfeeding jaundice, poor intake leading to the dehydration. Other causes: breast milk jaundice due to the substances in the breast milk delaying bilirubin metabolism, Crigler-Najjar syndrome or the Gilbert syndrome, conjugated hyperbilirubemia, direct hyperbilirubemia, hepatobiliary disorders, biliary atresia, neonatal hepatitis, infection, torch infections, sepsis, metabolic disorders, galactosemia and thyrosinemia. Clinical features like a physiological jaundice appears on day 2 to day 3, resolves by day 7, term of the day 14 preterm. Peak total serum bilirubin less than 12 mg in term infant, less than 15 mg in the preterm infant. Pathological jaundice appear within the 24 hours or persist beyond the 2 weeks. Rapidly rising bilirubin greater than 5 mg. Signs of underlying disease: hepatosplenomegaly or the poor feeding, getting teres, severe hyperbilirubemia, lethargy, hypertonia, seizures, opisthotonus, high-pitched cry. For the diagnosis, clinical evaluation like time of onset, progression and associated symptom. Cephalocaudal progression. Jaundice spreads from head to toe as the bilirubin levels rise. Laboratory investigations like total and direct bilirubin levels, blood group and Coombs test for the RH and the APO incompatibility. Hemoglobin reticulocyte count and the peripheral smear for the hemolysis. J6PD activity and other enzyme levels. Liver function test for the conjugated jaundice. For imaging, abdominal ultrasound and the HEDA scan for the biliary atresia. For the management, psychological jaundice, reassurance and the regular monitoring. Encourage the frequent breastfeeding. Pathological jaundice, phototherapy, converts the bilirubin to the water-soluble form for excretion, indicated based on the bilirubin threshold for the gestational and the postnatal age. Exchange transfusion for severe hyperbilirubemia or rapidly rising level unresponsive to the phototherapy. Treat the underlying cause. Antibiotic for the sepsis. Surgery for the biliary atresia. Avoid drugs exacerbating hemolysis in the J6PD deficiency. Kernicterus, irreversible brain damage due to the bilirubin deposition in the basal ganglia. Long-term complication: sensory neural hearing loss, motor deficit and the intellectual disability. Physiological jaundice appears after the 24 hours, peaks at day 3 to day 5, resolves by 1 to 2 weeks. Pathological jaundice appears within 24 hours, lasts greater than 2 weeks or involves rapidly rising bilirubin greater than 5 mg. Causes of the unconjugated hyperbilirubemia, hemolysis, prematurity, breastfeeding jaundice. Causes of conjugated biliary atresia, sepsis, metabolic disorder. Kernicterus, this is a severe complication of the untreated hyperbilirubemia. Phototherapy and exchange transfusion are the mainstays of treatment. Direct hyperbilirubemia, this is not treated with the phototherapy. The underlying cause must be addressed.